Hi, so we'll be recording today the session of September mock paper 3. Sorry, that's mock 14. I'm down with a bit of sore throat, but I understand your exams are nearby, so I'm doing my best to record this. So, SBQ1. See, one question in your exam would definitely be asked about OPG, as in they'll be giving you an OPG image and they'll be asking you to identify the error in the OPG, or there would be an error in the IOPA that would be given to you. So studying radiographic errors becomes very important. You can study from a book called as Langelis, or sorry, or even if you don't have any book, you can go on Google. You can type errors in radiograph, dental radiograph, OPG, and IOPA. You can study the PPTs on it. All right. So the first question is an OPG like this is given, and they have asked what is the error in this OPG. Now, see a few common errors in the OPG. Either the patient would be looking down, that is, the chin would be tipped too low, in which case the lower border of the mandible would be very close to the edge of the phlegm. If the patient is looking too up, there would be a big distance between this border and the upper border. If the patient is placed too forwards, then these condyles would be like at the edge of the phlegm out here. You see, the condyles would be here. If the patient is too far, then it's going to look like a very small image. So go through all the images, go through all the errors. So this particular radiograph, the chin is like very close to the edge. So it is chin tipped low. You cannot say that the patient is placed very forward because the condyles still have a distance from the edge of the phlegm. If the patient was placed too forward, then the condyles would be out here near the edge of the phlegm. Understood? So this becomes the answer. Chin is tipped too low. Now, what is the structure indicated by the arrowheads? It's both A and B. Now, what is A? A is hard palate, the floor of the roof of the hard palate. And what is B? That's the floor of the nose. For ENT people, the hard palate is floor of the nose. For dentist, this arrow is the hard palate. That is, we call it as hard palate. We don't call it as floor of the nose because it's very easy for us to talk about it, like there is a lesion on the hard palate, something like that. Instead of saying there is a lesion on the floor of the nose, then we'll be wondering where that is. So this is it. What are the radio opaque circular objects on the distal superior left side? That's near to 8. Radio opaque circular objects on the distal superior left side near to 8. Basically, they're asking about these structures. They are nothing but the ghost images of this screw and plates. I've given a big explanation for all the enrolled candidates. You can go through, or you can pause this video and you can go through the explanations. A male patient, 38-year-old who has worked in military, comes to you for consultation regarding his lower right premolar. Now see, this is a very important question. Why? Because it helps you to analyze how. See, whatever question the ADC will give you now, it's not just to create some random image in your head. Each word has a meaning. Each word, each word has a scenario attached to it. So when they say there is a male patient who is a 38-year-old and who has worked in the military, military means what? He was in war. Means he must have suffered some trauma here and there. You understand? And he's 38-year-old, so he's not that old. Military also means that he's pretty fit otherwise. He comes to you for consultation regarding his lower right premolar. He's asymptomatic. The key word is asymptomatic. There is no pain, there is no swelling, there is nothing. You just took a radiograph for a normal consultation and then you find a radiolucent area extending from 4.3 to 4.6. Now 4.3 to 4.6 is the lower border of the mandible and one of the most common regions for trauma, especially for a person who's involved in fights. And in this case, it's military. What is the most likely diagnosis? Traumatic cyst is my first guess. Dentigerous cyst, it cannot be because no tooth is missing. And dentigerous cyst is always around the crown of a tooth. Plus, it has to be associated with some expansion or pain, which is not the case. Odontogenic keratocyst, in this scenario, one tooth has to be missing. The question is not mentioned so. Aneurysmal bone cyst, that can be true, but given the question is telling you that the patient has worked in military, I'm going to go more with the traumatic cyst. It can be aneurysmal bone cyst also. If traumatic cyst wasn't given and some other option was given, I would have probably chosen aneurysmal bone cyst. But the answer here is traumatic bone cyst. Again, a lot of explanation is given. Go through it. Now, this patient has a finding at the apical region of the second premolar. What is your assessment? It looks like a compound odontome. I mean, just by looking at it, you don't even have to read the options. Second question. A female patient came to get her dental clearance done before starting denosumab. What is denosumab, guys? Denosumab is given for osteoporosis. It's also called as Prolia. And if anything happens with it, it falls under the category of medication-related osteonecrosis of the jaw. It is not a bisphosphonate, remember that. MRONJ is divided into BRONJ and denosumab. Understood? So, now if you have read therapeutic guidelines, it says clearly that whatever dental treatment you want to do, you do it at least 1 week before, minimum, maximum as far away from the injection site, but minimum at least a week before the administration of Prolia or denosumab. Now, in case you have already administered this, then all you can do is a basic composite filling, and for rest of the other things, you should take a GP clearance and then do it. So let's see the question. Which other supplements is she most likely to take while undergoing treatment? See, she is on osteoporosis, so vitamin D becomes the right answer. Again, read the feedback. What is the complication that can occur if extractions are done while the patient is on denosumab? See, what does denosumab does, and this can be asked in your part 2 exam OSCE also, so it becomes a very important question. Osteoporosis means there is dissolving situation of the bone. When you are giving an anti-resorptive agent, it means that the bone is not going to dissolve the way it is supposed to. It is going to reduce the capacity of the bone to resorb. Now, what happens in extraction? After extraction, the bone needs to remodel. Some resorption happens, some healing happens. But and bone resorption in that particular site becomes important because some healing has to happen, and it's a combination of both the healing and resorption that results in a healthy formation of the woven bone in the extraction socket area. Now, if the bone is not getting resorbed at all, sometimes the area fails to heal properly, and that is what results in osteonecrosis of the jaw. Now, because this is a medicine and it doesn't fall inside bisphosphonate, my option will be medication related osteonecrosis of the jaw. Denosumab is not a agent which is given for cancer, as in blood cancers. Meaning, sometimes you need to stop the tumor by giving anti-angiogenic drugs. Anti-angiogenic means they don't let the blood vessels develop in a particular area. Denosumab is not that. So my option C is not the right answer. My option A, that's MRONJ, is the right option. And this is not a bisphosphonate, so I'm not going to choose the option B. Remember this, a lot of people get confused even after reading 100 times. Denosumab is not a bisphosphonate. It falls under the category of medication-related osteonecrosis of the jaw. Understood? Patient taking denosumab every 6 months had to go to scaling and root planing as a part of a regular maintenance plan. When should the treatment be done? This question was asked in my own exam. Like I mentioned before, any treatment, do it 1 week before the injection has to be given. Now, in case this option is not given, then you can choose 3 months after denosumab or 4 months after denosumab. Understood? Her previous dentist did not tell her about the risk of osteonecrosis of the jaw. She was upset about it. Now, what is the most appropriate way to handle this situation? Very good question. See, this question is going to check your professional level. Now, just imagine you are sitting in your clinic. A patient comes to you and he tells you that he's just taken the denosumab injection and you have to extract a tooth because he's having some pain. So you check and you see, yeah, definitely the tooth needs an extraction. And then you ask, have you visited a dentist before? And the patient says, yes, like, just like 2 weeks before, just before I took an injection. And then you say, then why did you not remove the tooth then? So then the patient says, because the dentist did not ask me to remove. He said you can remove it at any point of time. Then you say, but you took the injection, and after taking the injection, it becomes a more risky procedure. So it would have been much better had you removed the tooth. And the patient says, oh, I'm really upset now. Why didn't my dentist not tell me before? See, I understand you're having a conversation with the patient, and the patient is in front of you. So, as a human nature, you're going to believe the patient. But patients can lie. And I'm sure all of you must have encountered this situation. That patient is a human being and patient is trying to save himself. He will not tell you that the dentist had told him to get the extraction done, but the patient himself delayed. And now he doesn't want to take the risk of getting blamed himself for not getting the procedure done. Or generally, the dentist must have not told him. Either case, you are not 100% sure that he was told by the dentist or not. So you cannot believe the patient blindly. So when you cannot believe the patient, you cannot blame the other dentist. And you should never blame your colleague. You can be that second dentist. The patient can go to a third dentist and say the same thing about you that you did not inform. You understand? So, in this scenario, you will never ever ask the patient to complain to anybody because, first of all, you just have the patient's words. You don't have the other side of the story. So, the best thing is to get the clarification about what was done with the previous dentist. But if the option says you will warn them about the potential complaint, it means you have already assumed that the patient is going to complain against the dentist and you are just trying to pass on that information to the other dentist. If the option would have mentioned that after taking patient's permission, you want to call the dentist and take the notes, then that is the first choice of answer. I have again and again said in the hierarchy of choosing the options, in the professional questions, the first choice would always be take permission from the patient and call or request notes from the previous dentist. If this option is not given, then the second option is advise the patient to talk to his previous dentist by himself. You will never ever going to just call and blame a colleague or tell him, you know what, this patient is going to complain against you without even knowing the story as to what had happened. Are you getting my point? You mark this answer wrong, you have high chances of failure because these special type of questions are given extra priority and you should get them right because it checks your level of professionalism and professionalism is a very important component both in part 1 and part 2 exam. Which dental treatment can be safely performed in the patient while on denosumab? Composite restoration. Don't overthink and think it's a class 2 composite and so you'll be placing matrix, wedges and bands. It's simple class 1 composite restoration. Okay. You cannot do anything that involves manipulation of the blood. Yeah, I understand supragingival scaling is an option here, but sometimes you can still cause bleeding even in supragingival scaling. But in a class 1 composite restoration, you cannot cause bleeding. I mean, it's a very, very rare chance. So that is the only thing that you can do. So yeah, I'll just stop recording now because I think I'm going to have a lot of sore throat again. I'll try and record as much as I can as I'm recovering. Tough days for me too. So I hope this is very clear. See, whenever you're reading a question like this, I expect you to, after reading a particular SBQ, go back to therapeutic guidelines or open your own notes or do a more research upon that question. Now, for example, if this question was on denosumab, I would like you to pause this video. Go read about more on BRONJ, MRONJ, ARONJ. See See when these drugs are given, if there is any dose mentioned, what all treatments can be done, what are contraindicated, how would you treat if a situation like osteonecrosis of the jaw develops. You are supposed to do all this lateral reading. You're just not supposed to read this question and move ahead. That is what is called as a thorough study method. Understood? So yeah, go read about this more and see you all later.